It's wonderful to have all of you join us today, and I am very excited about our very first lecture that I know is important to us, and it will be very informational. We're just days away from starting our spring semester, and I can't think of a more important topic for us to discuss and to learn more about, and that is COVID-19. Today, we're going to focus on the current landscape of COVID-19 and the latest news about the vaccine. Our university weathered perhaps our most unusual fall semester ever in our 180 years of being the first university in Texas. I attribute a great deal of our success not only to staff, but to three very special members of our faculty who have been sharing their expertise and have guided all of our efforts. And they are the moderators for this morning's lecture. Doctors Zwail Foote, Gonzalez, and McLean served as advisors on our campus readiness task force. Through their work and expertise, we put into place a very robust set of health and testing protocols for our entire community. And that allowed us to complete the fall semester and prepared us well for this spring. Dr. Maha Zwail Foote is a professor of chemistry at Southwestern. She earned a BS degree in chemistry with honors from Caltech and a PhD in biochemistry from the University of Texas at Austin. She joined the faculty at Southwestern University in 2003, and she is now a holder of the Gary Chair in Chemistry and a visiting scholar at UT Austin. Dr. Martin Gonzalez is an associate professor of biology at Southwestern with an expertise in microbiology, post-translational regulation of DNA repair, and mutagenesis. Martin has been following all of the updates about the pandemic as news emerges each day in the popular media and within the scholarly community. He received his PhD from the University of California, Berkeley, and his MS and BS from the University of Texas, El Paso. Dr. Scott McLean is a professor of kinesiology at Southwestern. He joined the faculty in 2001. His research focuses on exercise and sport biomechanics. Scott received his Bachelor of Arts degree from the College of Wooster in 1987 and his doctorate from Arizona State University in 1994. He's a member of the American College of Sports Medicine, the International Society of Biomechanics in Sports, and the Texas chapter of the American College of Sports Medicine. And now I will turn this over to Dr. Zwail Foote, who will introduce our very special guest lecturer.
Good morning. Welcome everyone to this webinar today. I'm absolutely thrilled to introduce Dr. Peter Hotez, the Dean of the National School of Tropical Medicine and Professor of Pediatrics and Molecular Virology and Microbiology at Baylor College of Medicine, and co-director of the Texas Children's Center for Vaccine Development, and he also holds the Texas Children's Hospital Endowed Chair of Tropical Pediatrics. Dr. Hotez is a world-renowned leader in the fields of global health, neglected tropical disease control, and vaccine development. He has been instrumental in the development of vaccines for some of the most prevalent neglected tropical diseases, and along with his collaborators, has developed a vaccine for COVID-19, which is currently in clinical trials. You've seen him on numerous news and media outlets, and he is a persistent and relentless voice for accurate and honest information about vaccines, COVID-19, and global health. If you follow him on Twitter, you might reach the conclusion that he doesn't sleep much. We invited him to Southwestern to discuss the latest news on COVID and vaccines and to answer questions you may have. The audience can ask questions in the Q&A box at any time during the presentation, and we'll have some time at the end to answer many of your questions. Dr. Hotez, welcome. We are so glad to have you here today.
Well, thank you so much. It's a real honor to be here. I've made one visit to Southwestern University. It was shortly after we arrived to Texas in 2011. I was a visiting professor for a few days and spent time on the campus, your beautiful campus, which I absolutely love. And I'd like to congratulate President Tremblay for becoming the next president of Southwestern University, and it's going to be very exciting. I think you have enormous capacity for doing important things and continuing on an incredible trajectory. And let me just say, one of the reasons that I moved is not just to be part of Baylor College of Medicine, Texas Children's Hospital, but to, really be part of Texas. And anything that I can do to help Southwestern University in any way, feel free to always count on me. I've mentored a number of students from Southwestern, and would enjoy continuing to have that capacity. The one thing we don't have at Baylor College of Medicine, which I miss a lot, are undergraduates. So when I was out before this, I was a professor at Yale for a decade, and then George Washington University, and I always love the opportunity to be able to mentor and work with undergraduates. That's the one piece that we don't have in our Texas Medical Center. So maybe you can help us fill that as a surrogate. I don't know how you want to work today. I've got a slide deck, but there's people have so many pressing issues that I'm thinking maybe give a more abbreviated presentation today and use the opportunity to answer as many questions as possible about COVID-19. I don't know how you feel about that, whether you think that would be wise to do. I mean, I have a more formal slide deck to present, but usually in this time of COVID, people are not clamoring for more PowerPoint slides. So maybe I think what I'll do, if you feel it's appropriate, is I'll talk for about 20 minutes maybe and give kind of where I see things heading with COVID-19, and then answer as many questions as people would like, and we could always do some follow-up after that. How does that sounds reasonable to you? Okay, thanks. Yeah, I mean, this has been an extraordinary year, and unfortunately, as exhausted as everybody is about COVID-19, things are not getting better. We're now at hitting 200,000, 250,000 new cases a day across the country. But remember what that really means, because that's an underestimate by a factor of about 4 or 5. So because the confirmed cases terribly underestimate the actual cases. So we're probably looking at 1 million new cases a day. And on that basis, when you look at the total number of people that have been infected across the country, around 20 million, we have to remember what that means as well. We're probably looking at upwards of almost 100 million people infected. So we're essentially basically a quarter of the country has been infected. And now we're at 370,000 deaths. We'll be at 400,000 deaths by the time of the inauguration. And that's a really chilling number. And that means something to me, because that 400,000 is the same as the number of American GIs who gave their lives in World War II. So we're talking about something on that catastrophic level for the country. And the other benchmark that I'm really worried about that we could approach by the spring is 640,000 deaths. And that's a chilling number, because that's the number of Americans who lost their lives in the great 1918 flu pandemic. So we're looking at something that may be one of the worst public health catastrophes that's affected the nation in the last 100 years. So the way to start out with is, how did we get there? And, I think from my opinions, one of the big issues has been we've just failed to launch a national response to COVID-19. We never put that in place. We insisted on having the states in the lead, and with the federal government having kind of a backup role for FEMA support and supply chain management and production. But that was never adequate. The states never had the epidemiologic horsepower and the models to know how to do that. They didn't have the wherewithal to know how to actually stop this virus using what we call in today's language non-pharmaceutical interventions, NPIs. You'll see the term NPI a lot, to the point where and there's been really horrible missteps every way. We've missed the entry of the virus when it came in from Southern Europe into New York City around late in January. We didn't pick up the first case for a month, so we allowed virus transmission to go on for a full month before we even knew there was a case of COVID-19. That was a tragic mistake. Then we really never got the diagnostic testing up to the level where we needed to be, and we're still struggling providing easy access for diagnostic testing. Then we failed to do anything to stop that horrible summer surge that really hit the southern states very hard, in a swath that went across Florida, the southeastern states, Texas, Arizona, and into Southern California. And then we failed again to stop the big surge in the Midwest. And, if you make two perpendicular lines, one going across the South and the other going up and down across the Midwest, it more or less lands somewhere around Georgetown, Texas. So Texas has been one of the big epicenters of this epidemic, and we've suffered terribly in Texas. We're at about 2 million confirmed cases and roughly 30,000 deaths. And let's look at those numbers. 2 million. Remember, 2 million confirmed cases really means close to 8 to 9 million new cases. So again, about a third of the state of Texas has been infected with COVID-19 by now, we think, and 30,000 deaths. I mean, that is probably more than any other catastrophic event in Texas history. The Galveston Flood, according to some estimates, 8,000 people lost their lives in the Galveston Flood. 20,000 Texans gave their lives fighting for the country in World War II, 3 to 20,000 for the Civil War. So we're right up there with 30,000 deaths. So this has been pretty awful. And again, we've not really had strong COVID-19 containment measures across the state. So, one of the big questions is, why did we come up small every time when it came to combating COVID-19? And we still don't have the answer. I mean, of course, people want to blame the White House, and the White House, did launch a disinformation campaign, which has caused a lot of distress. By that, I mean, starting in the summer, they took this pivot to say that COVID-19 was either a hoax or not a major cause of death, and they tried to attribute COVID-19 deaths to other comorbidities when we knew that wasn't the case. Or they claimed that the hospital admissions were really catch up because from March and April due to elective surgeries, and the list just went on, and that was really distress. Or they discredited masks, or and then spectacularized fake cures like hydroxychloroquine. And this was really one of the tougher things for me as a scientist, going on CNN and MSNBC and even Fox News at the time every day, because, the message that the university gives you, of course, is just stick to the science, don't go into the politics. And it got to the point where I didn't know how to do that anymore, because, I didn't link the anti-science to the politics, they did it. And so it was my job to disentangle it. And I didn't know how to do that without really calling it out. So I think maybe in our discussion, that kind of an interesting place to go. What is the role of a professor at a university when they're kind of thrown into this role of having to be a public intellectual and being, having to be thrown into the political atmosphere, and not just saying, no, I'm not going to do that, knowing that you had to do it in order to protect the country. I mean, I remember my wife, Ann, she said, I see this is really upsetting you. You're just going to have to, go out and attack the White House if you think that's what's necessary to save lives. And that's what I did. And it was a very scary, dark place to be throwing stones at the White House day in and day out. And you can imagine all the lovely messages I got on my email and social media because of that. Now, where are we at? Well, we've failed to control COVID-19. And we've really squandered almost every opportunity out there in order to do something about this epidemic. So all we have left is to vaccinate our way out of it in some respects. I mean, of course, there are other things we can do, but now the level of transmission is at such a screaming high level that I think when you get to that point, history tells us, whether it was combating measles epidemics or smallpox epidemics, we're going to need to vaccinate the American people. And once again, you know, we're realizing that there is very little in place. First of all, Operation Warp Speed, I think, was a good development program in terms of getting some new technology vaccines to the table, but many of us had the impression that Operation Warp Speed was more than that. It was actually, there was a roadmap and a plan to bring in the US military and National Guard to actually vaccinate people, because historically we haven't done much in the way of doing adult vaccinations. Like, you know, I don't know where everyone gets their vaccines in Georgetown, but here in Houston, I go to HEB or Kroger's or Randall's, and that's where I get my vaccines. And unfortunately, that was all that people seem to have in mind, to create an infrastructure for vaccinating the American people. And it's not working, right? I mean, how many of you are calling around to local pharmacy chains and seeing if you can get your mother, father, or brother, or sister vaccinated? That's not a way to do high throughput vaccinations. And this morning, I briefed the Texas delegation to Congress about how daunting that task is going to be. And you know, if you do some of the back of the envelope numbers, it's pretty daunting. So we did studies with the City University of New York to show that we have to vaccinate 3/4 of the U.S. population in order to interrupt virus transmission. And let's say we want to do that by the end of August. So we can do some simple math calculations. So that's 240 million Americans that we have to vaccinate over the next 8 months. So that's 30 million Americans a month. That's 1 million Americans a day. And some of the vaccines are 2 vaccine doses. So we're looking at roughly 2 million Americans every day now for the next 8 months. And so we're not even close to that. Let's bring it down to Texas, and there's a nice parallel with the math. So, 30 million Texans roughly. We want to vaccinate 24 million Texans by, let's say, by August, September. That's 3 million Texans a month. You get the idea, 100,000 Texans a day, 2 doses, 200,000 Texans a day. We're just not even close to that. But that's all we have. We're at a place now where we have no other choice but to figure out a way to make that happen. This is our last arrow that we have. And we can't make excuses for coming up small yet again, like we have every time. So what do we do? And so I had a piece come out in the Washington Post this week, and kind of laid it out there. And it was pretty stark, but I felt, again, it was necessary to let people know what has to be done. I think, first of all, again, we don't have a vaccine infrastructure. I mean, again, we have this 4-star military general put in charge of Operation Warp Speed for the logistics. And it turns out now that by logistics, what they really meant was getting the boxes onto the FedEx and UPS trucks and making certain they stayed frozen. That was the logistics. And then it was kind of dumped off to the states without much after that. And I don't know why there was miscommunication or what, but clearly the states were not ready to know how to vaccinate the American people. So that infrastructure now has to be built. And I think it's fine to use the pharmacy chains for reasons I've just said. I think it's fine to use the hospital systems, but we're going to need more than that. And that means opening up some large hubs and doing it safely, I think, in an open air venue where we can get large numbers of people through. And it looks like the rate of allergic reactions for these mRNA vaccines is higher than a typical vaccine. So for like an influenza vaccine or an HPV vaccine for cervical cancer or other cancers, that's roughly 1 to 2 per million is a severe allergic reaction. This looks like more like 1 to 2 per 100,000. So it's still a rare event. But what it means is if you are in a venue that's vaccinating a lot of people, you do have to have emergency resuscitation equipment available for the likelihood that you may experience one or two allergic reactions. So and that's another complication, that we have to keep people for 50 minutes after getting vaccinated. So that in itself adds considerable complexity. And this is the other thing that I've noticed over the year of 2020. Our health system has zero tolerance for anything complicated. The minute we throw in any modest level of complexity, and we saw this with the diagnostic testing, things grind to a halt. We just can't seem to overcome that. So this gets to the second point of what I think needs to be done. We have to make this exceedingly simple. Now, the CDC and the ACIP, the Advisory Committee on Immunization Practices, put in place these 1A, 1B, 1C criteria. And I think the 1A made sense, which was immunizing healthcare professionals and people in nursing facilities and assisted living facilities. I think that made sense to stabilize the health system and to vaccinate people at greatest risk. But after that, I'm a little worried that the rules are too fussy and complicated to understand and wind up becoming a barrier to immunization. So I think maybe we could talk about this in discussion. I think we're gonna have to liberalize this more than we're currently doing. We need high throughput, easy breezy, simple, if we're really going to get to the point where we can vaccinate large populations. I think the third point is we're not going to be able to do this with mRNA vaccines alone. I think the technology is still immature. We don't have the ability to scale this easily, to produce it in the amounts that we need. And therefore, we're going to have other vaccines get up. So I think now we're looking at trying to bring on board the two adenovirus-based vaccines from AstraZeneca, Oxford, and from Johnson & Johnson. I think hopefully we'll see those get up soon. Particle vaccine from Novavax, and we have our recombinant protein vaccine that we're now producing in India. So we've been making, last time I came to Southwestern is talked about our parasitic disease vaccines, making vaccines for the poorest of the poor. And essentially, we've tried to develop the vaccines no one else will touch because there's no financial model for it. And we have vaccines for diseases like Chagas disease and schistosomiasis in clinical trials. And then about a decade ago, we adopted a coronavirus vaccine program because nobody cared about coronavirus vaccines at the time for similar reasons. And of course, now everybody cares about it. But we've now been able to use our past experience and expertise to develop a low-cost recombinant protein COVID vaccine that uses the same technology as the hepatitis B vaccine that's now being given to tens of millions of children all over the world, and that we think this could come in as a good pediatric vaccine for the country, for the US as well. Right now, India, through Biological E, one of their big vaccine producers in Hyderabad, is making 1.2 billion doses. And that's exciting for us. We've never made a billion of anything before, and now being tested across India. So we hope this will make an important contribution, because right now we know the mRNA vaccines probably will not filter to low and middle income countries. So they're kind of left out in the cold, and we're hoping to fix that. So that's the third thing. The fourth is we need to communicate this better to the American people, because Operation Warp Speed was a strong program in terms of development, but they never put in place a communication strategy. They left that to the pharma CEOs, who were not strong communicators, made a lot of mistakes, and there was a lot of confusion about all the stock dumping and stock trading. And, we heard about leaked messages to JP Morgan investors, and this was a big turnoff for the American people. So we're going to have to build up our communication strategy. And at the same time, we have to recognize that we've got a very aggressive anti-vaccine movement in this country, especially in Texas. So the anti-vaccine movement is really very interesting. And unfortunately, a lot of it is centered around the Austin area. Kind of Austin is anti-vaccine capital of the world in many respects, because a lot of the thought leaders, if you want to call them that, are based in the Austin area. And then you have Texans for Vaccine Choice, which is an anti-vaccine political action committee lobbying the state legislature. So now This started off in 2015. That's when the anti-vaccine movement took this turn to political extremism, and political action committees formed under this banner of health freedom, medical freedom, and it's causing quite a bit of damage. We now have about 72,000 kids denied access to their vaccines in the state of Texas. We don't know anything about the homeschooled kids. There are more than 300,000 homeschooled kids in Texas. So we probably have over 100,000 kids in Texas not getting their vaccines. And what happened in 2020 is that those same anti-vaccine groups then glommed on protests against masks and social distancing. So it became a full-on anti-science movement. And I get involved in this because I have a daughter with autism and wrote a book called Vaccines Did Not Cause Rachel's Autism, which goes into the science and tells the story about, my 4 adult kids and with Rachel, who has autism and intellectual disabilities. And so that's made me sort of public enemy number 1. I'm now labeled by them the OG villain, which I had to look up. It means original gangster villain. So you're hearing from the original gangster villain today. For your inaugural lecture for this semester. So we're going to have to figure out a way to how we combat that, how we launch a counteroffensive. So that's where we're at. We have no choice. We've got to implement a pretty aggressive vaccine plan to vaccinate the nation, vaccinate Texas. And I don't know, I've spoken for about 20 minutes or so. Why don't I stop there and a lot of material and see what people are thinking and take some questions.
Thank you so much, Dr. Hotez. That was very informative, and we do have a number of questions, and we'll try to get through as many as we can in the remaining time. The first question.
By the way, if we don't get to all the questions, feel free to email me. It's just Hotez, Hotez, last name, and it's at BCM, stands for Baylor College of Medicine.edu. I'm known for how quickly I respond to emails, but in this crazy time, I've definitely not falling short on answering emails, but I'll try to get to whatever I can. Just identify yourself as a Southwestern faculty member, and I'll try to prioritize it.
I can verify the last time I emailed Dr. Hotez, I received a return email, and I think it was a little over 2 minutes. So I was quite surprised. Anyway, the first question asks, what are the risks, both short-term and long-term, for young people who have contracted COVID-19? And are there special concerns about athletes?
Yeah, no, good question. We're still, of course, on the steep learning curve about COVID-19. And one of the things that we've learned is, when it first emerged out of Wuhan in China, we thought of this as a respiratory illness. And we thought it was going to resemble the first SARS. So the SARS-1 that emerged out of southern China in 2003 was overwhelmingly a severe respiratory illness. This certainly has a respiratory component, but it's more a vascular disease. So what happens is this virus binds very tightly to a receptor known as the angiotensin converting enzyme 2, which in itself is a carboxypeptidase. And that seems to trigger a lot of vascular events and clotting, blood clotting. So what you're seeing are these microclots in the vasculature of the lung and in the heart, causing coronary artery thrombosis, heart attacks, causing vascular events, cerebrovascular events and clots in the brain, causing strokes. And that is why, we're so worried about COVID-19. So overall, younger people seem to do well with this virus, with some important exceptions. Those with comorbidities, especially obesity, diabetes, can get very sick. And our pediatric ICU at Texas Children's always has a number of teenagers, adolescents with severe COVID-19. So that's one population to worry about. And then, the vascular events and the impact on heart disease in athletes, something that we still don't really have our arms around, but something that has to be looked at very closely. And again, this is why, I feel it's important to liberalize our vaccination strategy, get everybody vaccinated, because we really don't know the full extent of the symptoms that we're seeing. But I do think it is incumbent on any athlete that's been infected to get checked out by their internist and possibly a cardiology referral, at least for some of the basic things around an EKG and heart function tests to make certain that there are no issues.
Okay, so next question. So it's known that we need to immunize, at least in the United States, we need to be immunizing over 1 million people per day. It has been suggested that to keep up with this demand, the United States should be administering 2 doses of half the amount or only give a single dose of the mRNA vaccine. Will this still be able to provide enough immunity to neutralize the virus?
Yeah, I've pushed back on that idea, and I explain why in the Washington Post op-ed, and a couple of reasons for that. One, so much of the problem is not having the infrastructure to administer the vaccines. So even if you went to a single dose, you still have that problem. That's one. The other is, when you looked at the virus neutralizing antibody data, all of the manufacturers aspire to make a single dose vaccine. So Moderna did, Pfizer did, J&J and AstraZeneca, Oxford, we did as well. But when you looked at the level of virus neutralizing antibody, which is how these vaccines work after a single dose, what you see is some people do mount fairly vigorous virus neutralizing antibody responses a single dose, but most don't. So the point of the second immunization is to bring everybody up to that high level. And so the way I say this is 2 doses is a vaccine, a single dose. You don't know if you have high levels of virus neutralizing antibody or not. And that's really a roll of the dice at the craps game. So when you hear that this is partially protective, what they really mean, it's not that it's partially protective for everyone. It really means that some people are likely fully protected after a single dose, but many have no protection, and you have no idea of knowing which category you fall under. And that's why it's really important. Anytime you have a strategy where you're liberalizing the vaccine, you have to make certain that you're able to get enough vaccine for the second dose. There are some who disagree with me. I was talking with my friend and colleague, Don Burke, at former dean of the University of Pittsburgh, and he seems to have some aware of data where that things are a little better than that after a single dose. But I think the bottom line is if you have a broken system for vaccinating people, the way to fix it is not to turn a good vaccine into a mediocre vaccine. It's to fix the system and get more vaccines in place.
Okay. The next question is, I'm concerned about the safety of holding classes in person, given the current state of COVID-19 in the Austin area. Local schools have gone virtual this week. UT Austin has gone remote until the end of the month. Do you think members of our community should feel safe teaching and learning in the classroom at this time?
I think if, when I talked to a lot of K through 12 groups over the last year, including school superintendents and some colleges as well. And I've spoken to Baylor University and University of St. Thomas. And what I've said is my biggest concern, of course, is the adults in the community, especially older individuals and those with underlying risk factors. And when I say older, everyone says over 65, but in fact, when you look at the CDC data in the Hispanic and African American communities, 30 to 35% of the deaths are under the age of 65. So I'm worried a lot about individuals in their 40s and 50s and early 60s. And so that's a long way of saying, I think if we can successfully vaccinate all of the faculty, all of the staff, and people who are in and around the shops around the college campus, I think that would greatly reduce the risk, knowing that you will see some of the students between the ages of 18 and say 23, 24, some could get sick, but overall, that if you could vaccinate all of the adults over, say over the age of 40, 45, I think that would be very reasonable. And I think that could happen by the fall. But I don't know how you do that right now with the way things are, unless you've got a program in place to vaccinate the faculty here and at Georgetown. There are a few things also to think about, which is that, as vaccine becomes more and more plentiful, you may want to even require the students to get vaccinated. So I'm not a big fan of vaccine mandates, but in many colleges campuses, you do mandate meningococcal vaccinations. And that might be a reasonable thing to do. Right now, you don't have the vaccines to make that possible, but these are things to think about for the fall. So I haven't really answered your question. I mean, I think had you had the ability to vaccinate faculty and the staff and local merchants in the area who are interacting a lot with the students, yeah, I think you could do that without a lot of hesitation, but I know that's not the case. So then it becomes a much tougher judgment call.
So can you speak to hospitalization rates and community spread in Central Texas specifically, and whether schools like SU should be adhering to guidelines to stay home? This is pressing since we're supposed to be bringing students back to campus soon. Should we remain online until we leave stage 5?
Well, I don't want to be too prescriptive, without knowing the full story. It's hard to answer that just sort of swooping in for a Zoom call and being able to answer that in a blanket way without, hearing some more of the nuance, what the history has been over the fall. Clearly, as we move into next fall, things are going to be much, I think things will be much easier to do this. It's still going to be a challenge, and I recognize the complexities of all of this.
So this is
I'm happy. At some point, I'd be happy to do is, with a much smaller group of decision makers, happy to have that kind of small group discussion to weigh the pros and cons of things. But to just go in and answer that now, without knowing how things are set up, what's being done would be unfair just to do that now.
So this is a multi-part question. So how long will a person be immune after testing positive or having a vaccine? Also, can someone who's been vaccinated or been infected become infected again?
Good question. So a few things. With regards to the durability of protection from vaccination, we don't know. So the way, and this is the only one of the things that, I don't like the fact it's called Operation Warp Speed because it built on a decade of research and development, which we sometimes gloss over. But the one piece that was accelerated were the clinical trials, in the sense that even though they were large, well-controlled clinical trials, we released vaccines through emergency use authorization after 2 to 3 months of collecting efficacy and safety data. And we had to do that for a reason, because when you're losing the lives of 4,000 a day, if you went through the full 1-year licensure process to collect a full year of efficacy and safety data, you do the math, we're going to get to 1 million American lives lost. So that was the reason for the emergency use. Now, the only problem with that is we don't know about the durability of protection. Is it 3 months? Is it 3 years? Is it 30 years? And it's going to be different for the different vaccines. So this is why, again, you want to have a very high level of communication, because that information's got to be conveyed to the public. So there's a good likelihood that at some point, even if you've gotten 2 doses of the vaccine, you may need a 3rd dose. And I just can't tell you whether it's a 3rd dose in the same year in 2021, or whether it's going to be in 2026 for a booster, or 2030, or in 2022. So we're going to have a lot of situational awareness about that. In terms of infection, it seems to vary depending on how severe an infection you had. So one of the things we've seen is those who've gotten severe infection and hospitalization and survived have, generally speaking, very high levels of virus neutralizing antibody. And those who are symptomatic but not hospitalized, sort of intermediate level, and those with asymptomatic infection or low-grade symptoms have low levels to begin with. And then what happens is antibody levels start to decline. So those with asymptomatic infections or low-grade infections, within a few months often have undetectable antibodies. So people say, aha, that must mean they're susceptible to reinfection. Well, it's not so easy. So for instance, my colleague Akiko Iwasaki, who's at Yale, she has shown that no, even though you no longer have measurable antibodies, you still have memory B cells, memory T cells, and you still could be immune. So we think that the durability of protection from natural infection is probably longer than we think. We just don't know for certain. Now, clearly, there have been cases of reinfection, but it's not been a lot. It's been a few dozen, but there's probably many more. So I still think it's an uncommon event. I think people who are infected and recover, for the most part, are not susceptible to reinfection anytime soon, but there are going to be exceptions. And then the question I'm asked is, therefore, should we not prioritize vaccinating people who've been previously infected? Well, the problem there is at least half of the people who've been infected never know it because they had asymptomatic infection. So half the people, a number of people on this call may have been infected and recovered and have antibodies. And the problem is, for a vaccination strategy, if you're trying to make it high throughput, there's no way to operationalize that. There's no way to easily start measuring who has antibody and who doesn't, and therefore make a decision on that basis. So because we have probably a fourth or a third of the population infected already, we're just going to wind up vaccinating those individuals. And I think it's okay because it'll act like a boost. So rather than, in this case, if you've been previously infected, by the time you get your first immunization, you're going to have a big whopping antibody response, and then you'll get a third dose, which is everybody's second dose. So I think, and that'll be fine. I don't see a downside to that.
So do we need to use masks and social distancing after we're vaccinated? And if so, why and for how long?
So the way the clinical trials were done was if you started feeling sick and you adhered to a list of certain criteria, a list of symptoms, you were supposed to notify your study coordinator. The study coordinator would do a COVID-19 test, and if you were positive, that was a case. So the vaccine was tested only to prevent symptomatic infection and serious infection, and for that, it did an excellent job. The problem is if during that study, if you had asymptomatic COVID, it never came to your attention, so you never notified anybody. So you don't know whether the vaccine also prevents against asymptomatic infection. It probably does, but we don't have the data to support it, and that's being done. So what does that mean practically speaking? So let's say I got my vaccine, but my wife and youngest daughter didn't. In theory, I could still be infected with the virus, be asymptomatic, and bring it home. So on that basis, even though I've been vaccinated and I know I'm not going to go to the hospital or the ICU, I would still wear a mask in order to prevent getting the infection. With time, as more and more people get vaccinated and we show it stops asymptomatic spread, then the masks can come off. But for the time being, I would say for the next few months, when you're out in public, whether it's indoors or outdoors, you're still going to need masks.
Dr. Hotez, do you see this with the number of individuals that are at least claiming that they will not be vaccinated? They will not be vaccinated. Last time I read it was anywhere from 30 to 40% of people that were asked this. Do we see, or do we have a concern about this becoming a seasonal kind of where every year we're dealing with vaccines again?
Hopefully the vaccine, there's a couple of statements in that. First of all, why do we get a flu vaccine every year? We get a flu vaccine because flu virus undergoes so many antigenic changes that you have to make a brand new vaccine every year. I don't think we're going to need to go there for COVID-19. On the other hand, we don't know the durability of protection, so you may need more frequent vaccinations for a very different reason. Not because the virus is changing so much as we just don't know how long-lasting the protection is, and you may need to get vaccinated. With respect to the anti-vaccine movement, I collaborated with a group of social scientists at Texas A&M led by Tim Callahan at their School of Public Health, and it wound up reproducing the results that the Kaiser Family Foundation found. And if we looked at the two most vaccine hesitant groups for COVID-19 vaccines, it's kind of interesting because they would seem like they have nothing to do with one another. So in our study, we found one vaccine hesitant group were Trump voters, and the others were the African-American community. And in the Kaiser Family Foundation study, they found what they called Republicans, so I guess same thing, and then the African-American community. So what's going on there? I think and this, we're going to need more studies to understand it better, but I think with the Trump voters / Republicans, again, this is part of this health freedom Tea Party movement that came out in 2015 and Texans for Vaccine Choice that were defiant of vaccines and masks and people who tied their political allegiance to defying public health control measures under this banner of health freedom, medical freedom. With the African American community, to me, that's a bit of a surprise. I mean, I understand the structural racism and historic racism and the legacy of the Tuskegee experimentation. But the truth is, for the last few years, that vaccine hesitancy has not been all that high in the African American community. So I was a little surprised when this happened, but it's real. I mean, I've been doing now, because in order to address this, I've been reaching out to both groups. I've been going on a lot of conservative talk radio shows and, the Daily Caller, and going back on Fox News and to address, the first part, but then doing a lot of African-American radio stations in and around Houston and Texas and in Chicago. And it's real. And, one of the things that I noticed was in 2018, 2019, the anti-vaccine groups started targeting individual communities. So they went after the Orthodox Jewish community, and they used very inflammatory language comparing vaccines to the Holocaust, and even giving people these fake yellow Jewish stars with the word vax written in them, making it look like Hebrew lettering. Is really offensive. But that's what they did. And then I noticed some of the same groups started organizing what they called these vaccine rallies, which were really anti-vaccine rallies in Harlem. So they were called the Harlem Vaccine Forum or Harlem Vaccine Rallies. And they even held one in the Riverside Church, which was one of the iconic churches of the civil rights movement, Reverend Sloan Coffin. So there's been some targeting of the African American communities. I just don't have the sense of how much of that vaccine hesitancy is due to that versus something else going on. But it's a problem, and we're going to have to figure out how to address it and really step up our communications. And I'm of the opinion, although I'm a bit of an outlier on this one, that we have to take it one step further, and that is take down some of the anti-vaccine content. And if you go to the Amazon site, Amazon.com, and you put books up at the top, like everybody has done, and then you press return, you'll get that scroll down menu on the left. You go down to the middle of the page to health, fitness, and dieting. You click on that. You'll get another scroll down menu that has the word vaccinations in it. Click on vaccinations. It's all fake anti-vaccine book, COVID conspiracy book. So, how do we get to Amazon? How do you get to Facebook to really begin taking down some of that content? I think that's going to be really important. You also have the problem that the Russian government has been filling our internet with bots and trolls and with anti-vaccine messages. And then you have the problem that we've been exporting our anti-vaccine movement to Western Europe. So there's been anti-mask, anti-vaccine rallies in Berlin and Paris and London. And in the Paris rally, they stormed the Reichstag, and New York Times, BBC reported it was linked to QAnon and political extremist groups, even neo-Nazi groups. And so it's really getting crazy and going to very dark places. And then you have to be careful how you message it, because, what have I said in the last 2 minutes? I've talked about QAnon and neo-Nazis and the Russians, and you start sounding like somebody who throws things at the TV at night. So, how you explain all of that, I haven't really figured out a way to say it in a way that sounds, everybody sort of understands it now, but how you say it in a way that sounds credible. And certainly doing that in, a 30-second soundbite on CNN or MSNBC, it just doesn't go over well. So we're going to have to fine tune how we do explain this.
Okay. Will the vaccine still work on the new SARS-CoV-2 variants coming out of the UK and Africa? Which
I think so. We have a collaboration with Duke University looking specifically at that now. They've got the virus and the pseudovirus, and I think, looking at some of the models that will cross protect. But this brings up another point of our coming up very small in our public health response. The Australian government now, in a consortium of universities, does the full genomic sequence on 50% of the virus isolates they get. In the UK, they're doing it about 10%. In the US, we're doing 0.3%. We're not doing genomic. We've only done 50,000 sequences. It's ridiculous. I mean, we lead the world in genomic sequencing, right? We've got the Broad Institute at Harvard, MIT, and the New York Genome Center, and Baylor and Houston Methodist and University of Washington, Seattle, Washington University of St. Louis, and we just never organized ourselves like so much of it. We should have 10 million virus sequences. There's probably homegrown variants that are here in the US that we've never picked up, and we've got to fix that as well.
So we know that people should avoid large gatherings, but what are the highest risk places for contracting COVID-19? And if you could be specific, that would be appreciated.
Well, anywhere you're indoors, in crowded areas, remember, with such a high level of virus transmission, any place where you're indoors with lots of people, you can be guaranteed at least some of them will have COVID-19 with this level of remember, a third of the population of Texas has now been infected. So if you go to a bar off campus and people don't have masks on, guess what? There's going to be COVID in that atmosphere, and that's a place where a lot of people are getting infected, and restaurants, and hopefully we can get people vaccinated as quickly as possible. And so that's where I worry. Any significant gathering of people, particularly indoors, particularly without masks, you combine those three things and you're going to get COVID-19 transmission.
So could you please address the neurological and long-term effects of COVID, which seem to generally be discussed less often than the respiratory and vascular illness?
Yeah, it's a good question. So we are seeing a lot of long-term, well, I couldn't say long-term because we haven't been around long enough, but we are seeing significant neurologic effects, both in terms of what people are calling brain fog, not being able to cognitively function at the level you did before getting sick, also strokes, cerebrovascular events, that's a big one, and also depression. So we're seeing a lot of unipolar depression come after that as well. And even individuals who their first presentation of COVID-19 is a psychiatric illness. So that's also getting quite interesting. So a lot of neurologic effect. It's a bad illness to get. And so this is not something you want to mess around with. And again, getting people vaccinated has got to be the priority.
From the pediatric standpoint, why do you think young children are not affected at the same rate as adults?
I don't think we know. One of the hypotheses or speculations is that there are a group of upper respiratory coronaviruses that circulate so coronaviruses are one of the causes of the common cold. So we know at least 4 different types of coronaviruses that do that. And so potentially children, where kids are circulating, getting lots of colds, they have previous coronavirus infections and that's protecting them. But it's pretty speculative at this point.
Athletes who have a positive COVID test must do an EKG before being allowed to return to play. Do you think this is a good way to make sure the athlete is okay? EKGs are expensive, and I've not heard about other places requiring EKGs, so I'm just wondering if this is a good and necessary step.
Well, I thought you were going to say something different. I said you're getting EKGs, but is that enough? Should we be doing additional tests? So I think an EKG is a modest thing to do. I mean, you can do it in an internist's office. I think, what's the value of it? Is it sensitive enough to pick up heart disease, or do we have to be doing something more? Good question for a cardiologist. We should
So
finish up soon because I'm
I
going to have
was,
to
yes,
go into my next
we're
Zoom.
running out of time. So just this is the last question. As a follow-up to the earlier question about vascular impacts on teens and young adults, since so many cases are asymptomatic, so that they never know if they're positive, should all teens and young adults have cardio follow-ups over the next year to monitor for problems?
That's a very interesting question. And I haven't looked lately at what the American College of Cardiologists is saying, but that might be an interesting concept. I think that gets to be a pretty expensive screening process, and I don't know what the yield of that is, but they may weigh in on that in time. And once I leave this Zoom chat, I may take a look. I don't think at this point they're making that recommendation, but it might be something that happens down the line.
Dr. Hotez, thank you so much for being open to answering all these questions. On behalf of Southwestern University, thank you so much for being with us today and sharing your knowledge, your expertise on a subject matter that has profoundly impacted every aspect of people's lives around the world. We truly appreciate your time.
Well, thank you. I have tremendous admiration for Southwestern and your mission, and after our apocalypse ends, I'm looking forward to maybe making a real in-person visit. I had a fantastic time on the last time I was there. It's getting on almost 10 years now, so it's about time for another visit. I think you're doing some extraordinary things, and congratulations to all your faculty. And as I say, if there are things I can do to help or provide some input, I'm happy to do that. And so I look forward to staying in touch with everybody.
As do we, and we'd love to have you on campus. We really would. So to everyone in attendance, please be safe and stay well. And thank you for attending.
Bye-bye.